Welcome to the Anesthesiology Journal Podcast, an audio interview of study authors and editorialists.
Hello, I am BobbieJean Sweitzer, an associate editor for Anesthesiology, and you are listening to an anesthesiology podcast designed for physicians and scientists interested in the research that appears in our journal. Today we are speaking with the author of a publication that appears in the November 2021 issue of the journal. With us is Dr. Gavin M. Hamilton. Dr. Hamilton is the lead author of an article titled Persistent Postoperative Opioid Prescription Fulfillment and Peripheral Nerve Blocks for Ambulatory Shoulder Surgery, a retrospective cohort study. Dr. Hamilton was an assistant professor in the Department of Anesthesiology and Pain Medicine at the University of Ottawa and Ottawa Hospital Research Institute in Ottawa, Canada, while conducting this study. He is currently working as a full-time anesthesiologist at the Queensway Carleton Hospital, a large community hospital in Ottawa, Canada. Welcome, Dr. Hamilton.
Thank you for having me on the show.
So let's start out. Maybe you can just tell us what the primary question you intended to address with this study.
For sure. So the primary question with this study that we conducted was to estimate whether peripheral nerve blocks were associated with a reduction in persistent post-op opioid use in ambulatory shoulder surgery. And for this, we used prescription fulfillment pharmacy data. The time frame that we were interested was the first year after the surgery. And the reason that we wanted to examine this issue is that we know that peripheral nerve blocks for shoulder surgery reduce early postoperative pain, but what was less clear to us, and I think is less clear in the literature, is whether peripheral nerve blocks are associated with a reduction in persistent postoperative opioid use.
So I think you used three different terms to kind of classify the patients into different categories of their opioid use, I believe, pre-surgery. And so I was hoping you could maybe define for us what you meant in the article by opioid naive, opioid exposed, and opioid tolerant.
Like you said, to quantify preoperative opioid use, we used a modified definition of the patient's opioid exposure status prior to their surgery that was outlined in a recent consensus statement in ANA. So specifically, the definitions for an opioid-naive patient was a patient with no history of opioid use in the 90 days leading up to their surgery. An opioid-exposed patient was a patient who had a history of less than 60 milligrams of morphine equivalent dose of opioid per day in the 90 days prior to their surgery. And then an opioid-tolerant patient was a patient with a history of greater than 60 milligrams morphine equivalent dose per day in the 90 days prior to surgery. And the reason why this classification is so important for our study is that the definition of persistent post-op opioid prescription fulfillment, which was our primary outcome, is based on the patient's preoperative opioid use.
Okay, and we're going to dive into that a little bit more. But first, we want to clarify a few more things. I presume since you only looked at patients who received I believe it was a 2-month supply of opioids that were at least 90 days after surgery and up to 1 year, as you stated. So the primary intent of your study was not actually whether the regional anesthetic technique provided acute postoperative pain relief, but rather whether it impacted only chronic opioid use. Is this correct?
So that's exactly correct. So we were primarily interested in the association of regional anesthesia and persistent opioid use in this population, so not the opioid use within days to weeks of the surgery.
And what type of study would you classify this as?
So this was a retrospective population cohort study, and it was conducted using routinely collected healthcare data. We conducted the study in Ontario, Canada, where a universal health system exists.
And how many patients overall did you have enrolled?
So in our study, there were 48,523 patients, and all of these patients underwent their elective shoulder surgery at one of 118 Ontario hospitals.
A lot of patients. And how were you able to determine if the patients filled the prescription postoperatively?
So to determine if patients filled a prescription postoperatively, we used the Ontario Narcotic Monitoring System, or short form NMS, which is a provincial system that was introduced in 2012 to capture prescription opioid drug claims for all of Ontario residents. And the way that this system works is that each individual pharmacy, they submit all their dispensing data for monitored drugs to the NMS. And this initiative was started back in 2012 to try to help facilitate a better understanding of the use of these high-risk medications in Ontario.
And were you actually able to determine if the patients took the opioids that they were prescribed?
Thank you very much for this question, and it's an extremely important point that you bring up. So since this was a retrospective cohort study, we were not able to determine whether patients actually took their prescribed opioid. We basically used the assumption that if a patient filled their prescription, then they took these opioids. So that is definitely a limitation of our study. And this is why we actually ended up changing the terminology around our primary outcome to be opioid prescription fulfillment rather than postoperative opioid use, which a lot of studies do use. Like I said, it's a limitation of the retrospective nature of the study, but we do know that the pharmacy data that we were using for the study is very accurate.
That's why you use that word fulfillment.
Yes, exactly. There's a little bit of back and forth between us and the reviewers about that one.
Sometimes we spend an inordinate amount of time over one word, right? So were the nerve blocks just single-shot regional anesthetics or catheter-based techniques or a mixture of these in this population?
So our paper included a mixture of both single-shot and catheter peripheral nerve blocks. So we identified whether a peripheral nerve block was performed on the day of surgery using the Ontario Health Insurance Plan, which is basically just physician billing codes. And with any retrospective study, it's really important that you use a validated outcome and exposure to ensure that we're confident with our conclusions. So as such, all of these billing codes for the peripheral nerve blocks were previously validated by our group against the clinical reference to demonstrate their accuracy. And they are both sensitive and specific at about a 97 and 94%. We're correctly identifying that the patient either had the presence or absence of a peripheral nerve block. And although that we did include both catheter and single-shot blocks in our study, we did find that there were just 4.5% of the nerve blocks were catheters, and the rest of the patients received a single-shot peripheral nerve block.
Got it. So I know in the past, many patients and providers actually believe that opioid exposure for acute pain or injuries or surgeries did not predispose patients to chronically use opioids. But I believe that logic has been proven to be faulty. What do we know about surgery and the risk of persistent opioid use?
So many times, surgery is the first time that patients become exposed to opioids. And there's quite a bit of evidence to suggest that after either acute care hospital visits or a surgery, many of these patients will go on to persistent opioid use. Now, as you know, this is very complex, and quantifying this risk is extremely challenging. The way that I find it a little bit helpful to think of the risk of persistent post-op opioid use or post-discharge opioid use, it's within a framework. So imagine you have a Venn diagram with three different sets. One set is the system factors, which include your prescribers, your healthcare system, and potentially patient follow-up. You also have then the surgical factors in a different set, which would include your type of surgery, the type of anesthetic that the patient receives. And then the third set would be your patient factors. And these factors are probably the most important factors. And what you'd include in there would be your risk factors for going on to persistent post-op opioid use, which would be chronic pain, preoperative opioid use, history of substance use, depression, things like that. So unfortunately, the evidence in this area is quite heterogeneous with varying populations and definitions for post-op opioid use, but in general, it's likely that the incidence of persistent post-op opioid use ranges from 6% in the low-risk, naive patient coming for a surgery to up to 60%, depending on those factors that I mentioned.
Those are also potentially those huge numbers, considering the amounts of surgeries that we do, correct?
Oh, for sure. for sure.
So can you tell us a bit more about the database that you used?
So we're fortunate in Ontario that I already mentioned that we do have a universal physician and hospital health insurance coverage. And because of this, all of the healthcare data in Ontario are collected using standardized methods, and they're stored at a research institute centrally. And so in our study, we utilized de-identified data from several of the different data sets. So, for example, one of the data sets names was called same-day surgery. Another one was called the Ontario Health Insurance Plan database, the NMS database, which I've already spoken about. And all of these databases needed to be linked to conduct our study.
And did you have a lot of detailed information about these patients, such as their comorbidities, and I assume you knew their age?
Yes, we did have quite detailed information on our patients. So for retrospective studies, as we are not randomizing patients upon inclusion into the study, like you would with an RCT, it's extremely important to be able to control for as many potential compounders that you can in your statistical methods. And because of this, we decided to obtain detailed information on demographics, comorbidities, preoperative opioid prescription data, preoperative patterns of healthcare resource use, because these variables are likely to confound the association between the peripheral nerve block and then persistent post-op opioid use. And just to give you an idea of the population that was included in the study, so the mean age of our patients was just over 50 years old. 34% of the patients were female. About 65 of these patients had an ASA score of less than 3. And regarding the preoperative opioid use, about 75% of the patients were opioid naive, 22% of the patients were opioid exposed, and 3% were opioid tolerant.
So a very small percentage of patients were using a large amount of opioids immediately before surgery, correct?
Yes, exactly. That's correct.
So quite impactful, I guess, if you did find some persistent use. So maybe tell us what you found.
So of the just over 48,500 patients that were included, 63% of the patients received a peripheral nerve block for their surgery. And then we found that 17% of patients, which was just over 8,200, went on to have persistent post-op opioid prescription fulfillment after their surgery. With regards to our primary analysis, we did find that there was a statistically significant association between the receipt of a peripheral nerve block and a reduced odds of persistent post-op opioid prescription fulfillment. The adjusted odds ratio was 0.9 with a 95% confidence interval of 0.83 to 0.97. Now, although this was statistically significant, the significance of the association that we found in our primary analysis is unknown, as when we went on to do our sensitivity and secondary analyses, we actually did not find a consistent relationship throughout our analyses between nerve blocks and a lower rate of post-op opioid prescription fulfillment. And then when we did stratify by preoperative opioid use status, 8% of opioid naive patients, 44% of opioid exposed patients, and 61% of opioid tolerant patients went on to have persistent post-op opioid prescription fulfillment. And we also found that preoperative opioid exposure did not modify the association of nerve blocks and post-op opioid use.
So if patients were using more opioids pre-op, they were more likely to be using persistent opioids, but there was no difference between the block and unblocked groups.
Exactly.
Got it. So were there any differences in chronic opioid use in the patients having the single shot versus the catheter? I know you said you didn't have a lot of catheter patients, but still your numbers were pretty big, so even that 4+%, right?
Yeah, exactly. So in our full population, we did find that the use of a catheter technique wasn't associated with decrease in persistent opioid prescription fulfillment. But interestingly, in quite a